turn it over to our amazing patient and family support coordinator, Amy. Take it away, Amy.
Thanks, Alyssa. Hello and welcome everyone to the Hirschberg Foundation for Pancreatic Cancer Research webinar, New-onset diabetes, a clue to the early diagnosis of pancreatic cancer. My name is Amy Reese and I am the patient and family support coordinator for the foundation. First, I'd like to acknowledge and thank all of our wonderful sponsors who help make these presentations possible. We've received a number of questions from our participants ahead of time, so we'll do our best to answer all of your questions after the presentation. Today, it's my honor to introduce Dr. Suresh Chari, Professor of Medicine with the University of Texas MD Anderson Cancer Center. Dr. Chari is a gastroenterologist, clinician, investigator with an interest in pancreatic diseases. From 1999 through 2019, he was a faculty member at Mayo Clinic in Rochester, and he led Mayo's Pancreas Interest Group and was director of the Pancreas Clinic, the primary entry point for all patients with benign and malignant pancreatic diseases. His research work, funded by NIH since 2003, focuses on early detection of sporadic pancreatic cancer in subjects with new-onset diabetes. We had the honor of having him speak at our 15th annual symposium in 2019 and are happy to welcome him back to be a speaker for this webinar series. Dr. Chari, welcome and thanks for joining us today.
Thank you, Amy. Let me share the screen here. Thanks, Amy. First of all, I'd like to thank Aggie and the Hirschberg Foundation for having me here, and appreciate all those who have joined us for this webinar. For all those who have lost a loved one, I'm deeply sorry for your loss. And for all those who are survivors and caregivers and others who are involved in pancreatic cancer, you are our inspiration for what we do here. What I'll do today is discuss something that I've been working on pretty much all of my professional life, and that's the link between diabetes and pancreatic cancer. I'll go over briefly about diabetes and the pancreatic cancer definitions, and then go over the state of our current issues with pancreatic cancer. What are the issues with the early detection of pancreatic cancer, and then talk to you about what the possible hope for the future is in terms of early detection. I chose this background of a dawn because I believe that there is a strong possibility of a dawning of a new era where early detection of pancreatic cancer is not hype, but is actual reality. So I just want to briefly go over these terms because there's quite a bit of confusion and a misunderstanding about what we are talking about here. So diabetes is actually a diverse group of diseases, almost 20 plus diseases. You may have heard of type 1 diabetes and type 2 diabetes, but there are a lot of other forms of diabetes, and it's by definition a condition where the body's ability to produce or respond to the hormone insulin is impaired. And this results in an abnormal metabolism of carbohydrates, which in turn is revealed to us as elevated levels of glucose in blood and urine. So it's a very generic term for conditions that lead to elevation in levels of blood glucose in the blood and urine. The American Diabetes Association has determined blood sugar cutoffs for defining diabetes and uses 126 on 2 separate consecutive occasions to define who has diabetes. The other common test for diabetes is hemoglobin A1C. A value of 6.5% or higher is considered diabetes. But when you go to your primary physician and there is a discussion about your glucose parameters, if you have not already been diagnosed with diabetes, there's often a delay between when the physician tells you you have diabetes and when your blood sugars might have actually have risen, partly because the physician often gives you time to lose weight and do other things to correct your sugar. And Unfortunately, that can be months to years before you actually hear the term diabetes. We use the term new-onset diabetes for diabetes within 3 years of meeting the blood sugar criteria, not when the doctor told you, but when you met the blood sugar criteria. This is very important because that first year is where most of the cancers will occur. Similarly, pancreatic cancer in the scientific literature is referring to a very specific type of cancer called pancreatic ductal adenocarcinoma. And I will use the acronym PDAC for that. But a layperson might think of pancreatic cancer as just a cancer of the pancreas, and there are many forms of cancer of the pancreas, most of which whom have much better outcomes than PDAC. And this discussion is specifically regarding PDAC or ductal adenocarcinoma. And these are grossly of two types in the sense that some run in families, and the ones that don't run in families are called sporadic ductal adenocarcinoma. That is in the absence of the family history. But most of what I'm going to talk about in terms of the diabetes and its relationship with pancreatic cancer and almost everything else applies to both familial and to ductal adenocarcinoma, sporadic cancer. So I'll go over some of the data on pancreatic cancer, and many of you may be familiar with this. This is a distribution of stage at diagnosis of pancreatic ductal adenocarcinoma. And you will see here that 50% of patients are actually being diagnosed at stage 4. And this small sliver is the one that's confined to the pancreas. And this big chunk of red chunk here is regional spread or local spread of the disease, which may or may not be amenable to removal. So we looked at 205 consecutive patients in Olmsted County while I was in Mayo, and these were patients in Olmsted County from 2000 to 2015, and they're consecutive patients in the community. They all got seen at Mayo for their care because there is no other oncologist or gastroenterologist in town. And so you can see here what is the treatment that these 205 patients with pancreatic cancer got. It's a reflection of the previous slide where 50% are presenting with advanced disease. Here you can see that 37% of patients received no treatment, and another 32% got a single agent chemotherapy. So you can see that 2/3 of the patients are receiving barely any treatment for the cancer. And the surgery is this group has received surgery, and this group could not get surgery but got chemo and radiation. Now, all this, if you look at the surgical group, you'll see that 23% of the total group had surgery. And so only a fraction of them end up getting surgery. And if you look at this group, which is in green, the surgery plus chemo plus radiation, this is what I call the full treatment for pancreatic cancer. And you can see that only 11% got it. So in today's world, only a very small fraction of patients are actually getting the full treatment that would give them the best chance of survival. And if you now compare this, the survival in this pie chart is very dramatic. The group that got no treatment, their mean survival was 3.6 months. The one that got everything got 48 months, had a 48-month survival. So you can see that if we were to move patients from no treatment or minimal treatment to anything more than that, you consistently improve survival simply from moving them to a higher degree of treatment. And our goal is to get as many patients into this green section and move them out of the blue section. Some of them are related to age, some of them are related to having other diseases that prevented them from getting treatment, but much of it is related to late diagnosis. So these are some of the facts. Again, you might know the lifetime risk of getting pancreatic cancer in this country is about 1.6%. That is, there's 1.6% of the population is going to get pancreatic cancer. It represents 3.2% of all new cancers. So it's the 12th most common cancer in the country. And in 2021, there was 60,000 cases expected in the United States. The 5-year survival is 10.8%. It's the third leading cause of cancer death in the US after lung and colorectal. So you can see it jumps from 12th most common cancer to the third leading cause of cancer death, mainly because it is a highly lethal disease. And it's set to become the second leading cause in a decade as it overtakes colorectal cancer, whose mortality keeps dropping. The striking observation here is that among all the major cancers, it's the only one without an early detection strategy. And to a large extent, it, they're mutually connected. It seems like it's presenting at a late stage, and so there's no early detection. Because there's no early detection, the mortality is high. So how does the disease normally progress? Like everything else, it starts within the pancreatic duct, confined to the pancreatic duct, and we call it carcinoma in situ. And it starts becoming invasive or invades into the duct at a very small size, about 10 millimeters in size, which is less than half an inch. And by 20 millimeters, which is still less than an inch, it's starting to spread outside the pancreas. And the average size of a tumor that's removed at surgery is more than an inch, about 30 millimeters. But this entire spectrum of what looks like removable disease, surgically removable disease, occurs pre-diagnostically, that is before patient becomes symptomatic. And by the time they develop symptoms, 85% are not amenable to surgery. So this is the problem we face in pancreatic cancer. So why can't we detect this cancer early? I'll go through each of the problems and what the potential solutions for them would be. The first is that it's an uncommon disease. I told you it's the 12th most common cancer. So if you look at the population over the age of 50 and you took 100,000 patients, subjects in the population, only 38 will get it, which is good that it's not very common. But that makes it also hard for us to do anything directly on everybody in the population. So it will require the screening to be done in a group subset that has a high risk for getting pancreatic cancer, higher than 38 per 100,000. We think it has to be nearly 10 to 15 times that risk before we get to a point where we can screen for pancreatic cancer. The other thing you saw was a late presentation. So when you have symptoms that are directly attributable to pancreatic cancer, it invariably means that the patient has advanced disease. So for reasons that are not entirely clear, it only gives symptoms when the disease is already advanced. And so detecting early pancreatic cancer will require screening asymptomatic or minimally symptomatic individuals for pancreatic cancer. Another challenge, because these patients are not going to come to a physician for anything because they don't have symptoms. The third thing is the only marker we have for pancreatic cancer is CA19-9, and it's very insensitive to pancreatic cancer. So need an alternate biomarker for early disease. And it's non-visualization on CT. So we have done studies to show that the high resolution CTs are better than the standard ERCT you get, but you go back a year and it becomes very insensitive. So if you go back a year, probably 15% of cancers will be visible a year before their diagnosis on CT. So there is a major need for detecting pancreatic cancer non-invasively, but I'm hoping that even these which are not visible on CT can be seen on endoscopic ultrasound. That's needs confirmation, but at this point, based on what we think is the size of the tumor at that time, it should be visible on a endoscopic ultrasound. So when we put all this together, this is our vision for early detection. Yep, what we call the DEF approach to pancreatic cancer. Define a high-risk group, enrich that high-risk group for pancreatic cancer, and find the lesion. So our entire approach has been based on trying to use this paradigm to to get to the early detection of sporadic pancreatic cancer. Others have said that this can be done using two biomarkers. So you use a biomarker like a blood test, and you enrich the population using that, and a second biomarker further enriches it, and now you're getting to a point where it's possible, cost effective to use more expensive tests to identify the process. The other possibility that we are using is you use a clinical indicator for the first step and use a model or a biomarker to enrich that population and then use the CT or MRI. So that's what we are doing here. We're using new-onset diabetes as our first step. NPAC score, I'll go over what that is as the next step to enrich the population, and then using CT or MRI to identify the lesion, and then using endoscopic ultrasound to actually find the lesion and biopsy it. So I will talk to you about a study that is about to launch, which is called the Early Detection Initiative for Pancreatic Cancer. This is an amazing, unprecedented collaboration between the Pancreatic Cancer Action Network, or a non-NIH organization, and NCI, National Cancer Institute, to come together to do something that would move the needle in terms of early detection of pancreatic cancer. And the study itself is called Early Detection Initiative. And it's using new-onset diabetes as the first step towards identifying pancreatic cancer. And so the goal of the EDI is to develop a rational evidence-based strategy to detect pancreatic cancer early. So you may ask, why new-onset diabetes? So I'll go over the rationale for why we even started down this path, and why we're using this as the first step towards discovering pancreatic cancer early. So there is the connection between diabetes and pancreatic cancer has been known for 150 years. But it was only in the last, and we have been working on it for 20 years, and whatever we found 20 years ago is what we find today again. Others are finding the same thing. So what we found when we started all this was already known before us. So it's been a lot of repetition of the same findings. But somehow for the first 15 years of my work, I could be talking to a wall because nobody was paying attention to what I was saying. I'm not sure, lots of reasons for it, we can go into that, but the evidence for it was already there before we started. But there is a series of studies we did in the last few years of my stay at Mayo that appeared to be the most elegant and most convincing to people who were on the sidelines before this. So this is that same set of 215 patients I showed you the data on before. What we have done here is taken all those 215 patients and identified two controls for every patient. So there is about twice the number of controls in red here. And we pulled out their blood sugars, fasting blood sugars from the chart, and plotted the blood sugars over time going back 5 years. So to the left of your screen is -60, that is -60 months, that is 5 years, and 0 is at diagnosis of pancreatic cancer. So we took cases and we took controls, we pulled their fasting blood sugars, and we plotted the blood sugars going back in time up to 5 years from diagnosis. And what we see here is that between 30 and 36 months, the two curves diverge significantly. So the blood sugar in the cancer patients is significantly higher than that in the controls between 30 and 36 months before diagnosis. And after that, the glucose keeps rising all the way to diagnosis. And somewhere around the 9-month mark, it crosses what is the American Diabetes Association would call the diabetes threshold. But even before that, it's high. But the diabetes threshold is artificially, and not artificial. It's related to cardiovascular outcomes because of high sugar. It has nothing to do with pancreatic cancer. But we use that because that's what everybody understands and easily relates to. But the cutoff for where we should be looking for pancreatic cancer may be different for pancreatic cancer compared to cardiovascular outcomes. We haven't gone there yet, but I would suspect it won't be as high as 126. It could be as low as 115. Regardless, this graph basically shows that the glucose levels keep rising as you come closer to the diagnosis. And there's a window of opportunity to detect pancreatic cancer if we were able to tell these two forms of diabetes apart. So I told you before that there were many, many forms of diabetes, and type 1 and type 2 are the common ones we all know. The ones in red here are type 2, have a mixture of type 2 diabetes in them. But the diabetes in pancreatic cancer is very unique. It's caused by the cancer. And when you remove the tumor, the diabetes goes away or at least gets better. So it's something that the tumor is producing that's causing the cancer. And we don't know yet what it is that it is producing. We don't know yet how to differentiate the two forms of cancer. That would dramatically improve our ability to separate these two types of diabetes. But at this time, they're using other ways to differentiate these two, and I'll tell you what that is. But this is good evidence that the cancer causes diabetes and that there is a window of opportunity to diagnose this condition if there was a way to tell these two apart. The other way of looking at this is what is the status of patients with pancreatic cancer in regards to their diabetes at the time of diagnosis of pancreatic cancer? And this pie chart tells you what is the status of their diabetes at the time of diagnosis. So it's the same 220 patients. 22% had new-onset diabetes. 20% had long-standing diabetes. By long-standing and new-onset, I use 3 years as the cutoff for new-onset versus long-standing. Advanced pre-diabetes is that small wedge that is before they develop diabetes. They have fairly high sugars, but not yet meeting criteria for diabetes. And then there are others which have lower levels of glucose, but they are not normal. That's called impaired fasting glucose. And only 9% of patients have a normal fasting glucose. This is like, there's no other disease where it compares in terms of the number of patients who have an abnormal glucose in this setting. It's just an incredible, highly diabetogenic disease. And so this is very striking as well. So I had asked the question early on that if pancreatic cancer causes diabetes this commonly, would there be a higher risk of cancer in those who got diagnosed with diabetes? So we're looking at it the reverse way. So we went back to the Olmsted County population and we looked at everybody who had got diagnosed with new diabetes. So there was an epidemiologist at Mayo who was interested in diabetes, and she had meticulously identified patients with diabetes based on their glucose criteria, not based on what the physician told them that. And she had already organized this cohort of patients with new-onset diabetes. I just went and looked at how many got pancreatic cancer within 3 years of that time at which they developed diabetes. And we found that those who had new-onset diabetes over the age of 50 had 6 to 8-fold higher chance of being diagnosed with pancreatic cancer within 3 years of that, the day they met criteria for diabetes. So this is one of the first clues that this group of patients with new-onset diabetes over the age of 50 is a high-risk group for pancreatic cancer. I'll show you where this risk lies in relation to some of the other more traditional cancers we deal with. But this is a pretty significant finding that if you develop diabetes for the first time after they're 50, your risk is around 1% of having pancreatic cancer. So this shows you the relationship of that risk that I just showed you in relation to some other common cancers and the risks in them. For example, if you do a colonoscopy in subjects over the age of 50, the chance of finding colon cancer in that group is actually even less than what I put here. It's 0.7%. The largest study, which was done with Cologuard, screened 10,000 subjects for colonoscopy, with colonoscopy, and found 0.7% had colon cancer. So very much in the range that we are talking about with new-onset diabetes. For breast cancer, if you took people over the age of women over the age of 40 and did a mammogram, you would find a very similar risk. Same thing with heavy smokers, 30-pack year history, and you did a CT scan on them, same risk. So the ballpark risk of finding cancer in new-onset diabetes is very similar to that of the big three, colon, breast, and lung, where there is already ongoing screening in these populations. But most people are not satisfied with the risk that is not very different from that of lung or breast or colon. They would like to enrich this further in order to find a very high risk group for pancreatic cancer. So we set about looking at who develops diabetes and who develops pancreatic cancer, how we can tell these two apart. And we made an observation, right? 20 years ago, I made this observation, and that observation has repeatedly been confirmed. And that is that diabetes and pancreatic cancer develops in the face of weight loss. This is a completely opposite of what you'd expect in type 2 diabetes, where if you lost this much weight, your diabetes would go away. Here, you're losing weight even as your glucose levels are rising. So this goes back 5 years, and this is a diagnosis. This is weight, and this is fasting glucose. One is going up and one is going down. So this is a pancreatic cancer diabetes paradox, that weight is going down even as the glucose is going up. And we use this phenomenon that has been striking and has been repeatedly confirmed in our studies to our advantage to try to enrich the population of patients with new-onset diabetes. So we developed what's called the NPAC score, enriching new-onset diabetes for pancreatic cancer score. And we used age. There's a difference in age at which new-onset diabetes develops in type 2 diabetes and in pancreatic cancer. And there's a significant difference. So we took age, and as I showed you, there's a change in weight over time. So we would expect type 2 diabetes to be gaining weight, and we expect pancreatic cancer patients to be losing weight. So change in weight, and the rate at which the blood sugar goes up in pancreatic cancer is dramatically faster than in type 2 diabetes. So the rate of change of glucose over the past year. So these are the three factors that go into the NPAC score. And when you calculate the score, it divides the new-onset diabetes into three categories. Score of less than 0 is very low risk. It's almost all type 2 diabetes. And then there is very high risk, and they have a 3.6 to 6% chance of having pancreatic cancer. And there is an intermediate risk of 0.3%. So this score nicely divides the group into three categories. And we now have a very high risk group for pancreatic cancer. Now, this group with very high risk has almost a 30-fold increased risk of having pancreatic cancer. So if you look at the 3-year risk, NOD or new-onset diabetes is 0.85%. If you use NOD plus the NPAC score, there have been a couple of studies that have confirmed these findings. They also go up 3 or 4-fold from the baseline risk, but the baseline risk was lower, so they come up with 1.5%, and we came up at 6%. So it depends on how you look at it, but it's 3 to 4-fold enrichment of the new-onset diabetes cohort, and then we do CT or MRI and an endoscopic ultrasound to find the lesion. So this is the clinical indicators, biomarkers, imaging, and this is the EDI approach. Take new-onset diabetes, enrich it with the NPAC score, and image it with CT. And in those who cannot tolerate CT, you do an MRI. And if you find something there, you do an endoscopic ultrasound. So the question that's asked is, will it pick it up early? Will it make a difference? So as I showed you before, this is a graph, and this is where diabetes happens around 9 months before. And you can ask whether 9 months will make a difference or not. So this study we did, we took patients who had another scan. They all had pancreatic cancer, and there were controls, of course, but the patient with pancreatic cancer had another scan done 3 months to 3 years before their diagnosis of pancreatic cancer. They had some other reason for getting the scan. Um, and we had them mixed up with controls, and we had radiologists looking at this, not knowing whether the patient had cancer or not. And we then classified the findings as being very suspicious for cancer, and whether the cancer was resectable or not. And what you see here is that as little as 3 months to 6 months before, this is a resectability, the proportion of cancers that was thought to be resectable on the CT scan. As little as 3 to 6 months before, the resectability is as high as 60% compared to 15% at diagnosis. So even going back 3 to 4 months, you give the patient a decent chance of having a resectable disease. And if you go back 6 months, you can make a dramatic improvement in resectability. So we think turning the clock back even 6 months can make a huge difference in terms of resectability. I do not believe this is the final step. This is the beginning. Once you learn to walk back, you can walk back further. But this is where we want to start. We want to start by making the patients resector candidates for resection, and then see how we can do even better than that. So the early detection initiative is to determine if intervention at the time of new-onset diabetes, that is enrichment of new-onset diabetes plus the CT, that's the intervention. We are enriching the population of new-onset diabetes using the NPAC score, and we're using the CT scan to find the lesion. And if this intervention done at the onset of diabetes can result in earlier detection of pancreatic cancer, that's what this study is doing. And it aims to change practice guidelines. That is, if you get new-onset diabetes, you got to do something about it. It's a randomized controlled trial, so it is a very rigorous, the most rigorous scientific way to test the hypothesis. And it's collaborating with the NIH and NCI to make this happen. So this is the design of the study. We are taking 12,500 subjects with new-onset diabetes. We are randomizing them to observation arm versus experimental arm. A group of these patients will have their score calculated, and those who have a high score will be given 2 CT scans at least 6 months apart. And if there's anything on the CT scan, they'll get an endoscopic ultrasound. And the goal is that we would reduce that 50% stage 4 disease by at least 30%. And that we will make the stage shift, the cancer diagnosis, and change the profile of the stage at diagnosis. And the consent is obtained afterward. This is a innovative design that allows us to consent only those patients who will have the intervention, and rest are followed passively. So I'd like to stop here and acknowledge the work of amazing scientists and gastroenterologists and endocrinologists who over the years helped develop the evidence to support this kind of study. It's a nationwide study. It's a very elaborate study. It's taken a lot of effort, and the NCI and the NIDDK have stuck with us and supported us this far. Of course, the Pancreatic Cancer Action Network is doing its part to support the early detection initiative, which is a part that actually creates a pathway for a clinical pathway for early detection in patients with new-onset diabetes. I'll stop here and take questions. Thank you.
Dr. Chari, fascinating information. Thank you. This early detection initiative is such an important study. What when might we know some results?
So it's taken a while to get all the regulatory part set. So we heard the last week the first site got approval to start recruiting patients. So we hope to recruit fast. So I can't tell you, but I hope that in a year's time we will have preliminary evidence to show that we are on the right path.
So we had some questions that came in during registration. George asks, what is the ideal A1C value and which test or tests will determine new onset diabetes?
So the test for diabetes is the same. The A1C is what we use. 6.5 is considered by the American Diabetes Association to be the threshold for diagnosis of diabetes. 5.6 or so is normal, and anything in between is called impaired fasting glucose or impaired glucose tolerance. So the ideal would be you stay normal, but as you age, you tend to drift into the 5.6 to 6.5 range. But staying below 6.5 is what you want to be in terms of avoiding diabetes. So it's not that if you avoid this diabetes is caused by the cancer, so you can't really avoid doing that. But if you are unable to keep that under control, then you have to be suspicious that there's something going on.
Great. And in the chat, Dustin asked, to clarify your point earlier, do you believe PDAC causes new onset diabetes or is it vice versa?
It's a the multi-directional connection, and the connection between long-standing diabetes and pancreatic cancer is fairly modest. The risk in patients with long-standing diabetes or having pancreatic cancer is 1.5 to 1.8 fold higher. So if in the general population is 1, then those who have got long-standing diabetes have a 1.8 fold higher risk. New onset diabetes goes into the 6 to 8 fold higher risk. So the new onset diabetes is being caused by the cancer, and that's a we call it a symptom of the cancer or a marker of the cancer. Long-standing diabetes is probably a risk factor for developing pancreatic cancer, but it's a very weak risk factor.
Thank you. And Samantha asks, barring the cost, what tests can be taken that might indicate the possibility of pancreatic cancer? MRI, a change in blood sugar levels, or any other tests or markers?
So in the next year, I think we will see multiple blood tests for multi-cancer detection. I already know of 3 of them that are very close to coming to clinical use. These are interesting concepts. They claim that with 1 drop or 1 blood draw, they can identify cancer, first of all, and then tell you which organ has the cancer. And it remains to be seen how well it does in the setting of no symptoms, that is when you have no symptoms, and how well it is actually going to be, the false positives are the ones that drive you crazy with all these tests, because if you tell somebody you have cancer, then you don't find it, it just drives you crazy. It's psychologically very damaging. So that's the part which we don't know, that these tests will, how much false positive they'll draw. So there is a massive push for using these blood tests for early detection. And so we'll see where that goes, but there is a lot of promise there. But we think that even better would be to use them in a high risk setting, so your false positives are much likely to be much less. And so you use new-onset diabetes and use one of these tests that detects cancer, and then instead of using the NPAC score, you can use that. So there is great hope for a combination of factors being used to detect pancreatic cancer early.
And Stephen asks, will the new Immunova IMRAE PanCan-D screening test lower the cost for broader screening?
It's one of the players in the market. I told you this. This is the one. There's another test called Gallery, and there's another. So there's Cancer Seek. There's multiple players in the market now, and we hope that. And some of them are doing direct to consumer marketing. They're bypassing FDA approval and doing direct to consumer marketing. So the bigger question is the insurance approval for working up a positive test, and that will depend on how good they are. If they prove to be very accurate and that when they tell you you have cancer, then insurance companies will approve using that test for detecting cancer. And so everybody's anxious. So many of them are collaborating with us to try to test their markers in this EDI. And so we are in active talks with some of these companies to test their tests in a prospective way in our protocol. The hurdle is, what do you do with a positive test, and who's going to pay for the workup? But all that will solve itself over time as larger studies get done. So.
And Catherine asks, would twice yearly amylase help in detection?
Not that I know of. Amylase and lipase are not very good indicators of pancreatic cancer, so I wouldn't rely on them for detection of pancreatic cancer. So,
Amy, can you open the or turn off the red spots so that everybody can join in, so they can ask questions as well?
Alyssa, are you, Alyssa has a chance. You mean to unmute everybody?
Yeah.
And they can unmute themselves too at this point.
I would like Miklos Sashentos, doctor from UCLA, also to make a comment, because his work is, very much coordinated with this.
No, thank you, Agi. Suresh, it was great. I mean, finally I'm understanding it too. So, even after enrichment, you still have a detection problem, right? Because the risk remains around 1 in 20, or even long. So you still have to rely on CT and MRI, which you said is not sensitive enough for you. So how would the clinical management look like?
So, the CT MRI should still probably be done in those patients, but if our studies show that the NPAC score, or in case of a biomarker, the biomarker or the NPAC score are really strong indicators of underlying pancreatic cancer, I would not stop after a negative CT. I would do an endoscopic ultrasound and look for the cancer. So, I mean, there are new PET scans that are being developed for pancreatic cancer. Who they say the resolution is going to be good enough. And so if there are other imaging techniques that can identify the cancer, then we could go down that route. But until then, an endoscopic ultrasound would be the way to go. The biggest question at this point for the EDI was whether to allow an endoscopic ultrasound in everybody. And at this point, it becomes cost prohibitive. So it's being offered only to patients with an abnormal CT, but not at the research cost, but under a clinical category. So, but I agree with you that the imaging remains weaker as we go back in time, and I don't know how we're going to solve that. It needs a new modality of testing to be able to pick that up. We are also looking at radiomics. So radiomics is a artificial intelligence analysis of the CT scan. And according to the hope or the hype, the radiomics artificial intelligence can see what the eye cannot see. And so if that is true, then the radiomics technique might tell us that this CT scan is actually not normal. and then patient needs an endoscopic ultrasound. So all these approaches are being attempted, but we know that we have to do better in terms of imaging for us to be able to go back in time further.
I have a billion questions.
Yes.
So early onset diabetes, as a child, you have diabetes, does not mean that you will have pancreatic cancer. Is that correct?
No.
I'm wrong?
So I know one of the issues with looking at type 1 diabetes, which is what occurs very early on, is that at least till recently, their survival into the 60s and 70s was not very high. So they would get complications before that, and they would not survive to be 70. So we couldn't get a good handle on what the risk of pancreatic cancer was. But at this point, that is not considered a high-risk group for pancreatic cancer.
So this patient group you
Wait,
studied,
one more.
sorry,
I'm sorry, one more. So how many is diabetes in what percentage of a pancreatic cancer patient has developed diabetes at the same time? Everybody?
No, everybody shifts their sugar somewhat. If you are 70 at the beginning, you get to 90. If you're 110, you become diabetic. So everybody moves their sugar. But the people who cross the diabetes threshold for the first time at that age will be 25% of pancreatic cancers. Another 25% that already have had diabetes 5 years ago, their sugars will go out of control. So everybody moves their sugars. Those who have diabetes get diabetes that is poorly controlled. And those who have no diabetes or mild impairment in glucose, they become diabetic. So it touches almost everybody, but a subset of them cross the threshold of diabetes.
Natalie, I think I cut you off. I'm sorry. Go ahead. Natalie?
I would like to ask Doctor something.
Yes.
In you spoke about the preceding time of an actual diagnosis of diabetes, or the 2 or 3 year preceding time. Does that, what is pre-diabetic? And supposing a doctor gave you medication like glucophage to control that, would that delay the onset of your pancreatic cancer?
Not really. So this diabetes is being caused by the cancer. So it's already there when you develop that. So there's no way to delay it by controlling the diabetes. What would happen if you actually took glucophage or whatever else your doctor has given to control your prediabetes and it actually gets controlled is unlikely to be pancreatic cancer. Because pancreatic cancer the diabetes doesn't respond very well to treatment. And so patients who have diabetes of the usual sort and get treated and their diabetes remains stable or gets better are probably having usual type 2 diabetes. And so one of the peculiarities of this diabetes is that it is difficult to treat.
Thank you.
Steve Merlin, you had a great question ahead of time talking about the American Diabetes Association putting on educational programs for both the public and, more importantly, physicians to consider late onset diabetes and proactive diagnostic testing. So do you know how they might be
I
involved?
was just about to ask that. I also wanted to thank Dr. Chari for the talk. And if you recall, we met in Bern last year at the World Pancreas Forum.
Yes.
And I've encountered a lot of people where they've been diagnosed with late stage diabetes and their physician is not aware of this link. So they're going for quite a while before they're ever diagnosed with pancreatic cancer. And at that point, it's stage 3 or stage 4. So I was wondering what could be done with.
I'll tell you an anecdote about that. Amy, what was the first question?
about American Diabetes
Oh,
Association
yeah.
putting on
Yeah,
programs.
so, when we started down this study path and the NIH got interested in everything, we were putting together this original study 5-6 years ago. The first thing we did was go to the ADA. And actually, we got a very good response from them. And they actually offered to open up all their offices for any education material we might want to put there. But the unfortunate part is they didn't lift a finger to do anything for us. And actually, that ties into the anecdote I'm going to tell you and the question you asked. I got a call many years ago from a patient. I was in Mayo, and this patient was in Texas, and she called me and said, "I want you to talk to my doctor." And she was not my patient. She was some person who was diagnosed with new-onset diabetes, and so she had done her research, and she called me and said, "I want you to talk to my doctor." I said, "What happened?" She said, I tell him I've got new-onset diabetes, I'm 70 years old, and I am worried about pancreatic cancer, and he's doing nothing about it. And so I said, I'm happy to talk to him. So I got on the phone and spent some time with him, and he listened to me. And at the end of it, he said, "Dr. Chari, I've heard what you have said, and I've been practicing diabetes for the last 30 years. And I've got one of the largest practices of diabetes in Texas. I don't know what you're talking about. I have no idea what you're talking about." And so I respected him for what he said, because he was obviously a very busy practitioner who did not see this connection. So why? So we went back and looked at our data and said, how many of our patients with new-onset diabetes actually see a specialist? And it's a very small fraction. Because when you start on the road to with diabetes, your first few years are managed by a primary care physician. A primary care physician would not be considered worth his salt if he were to send you straight away to a diabetologist for care of recent onset diabetes. They would manage it themselves. So the endocrinologists who rarely see this. So we have had a very hard time getting on the platform of the ADA or the NIDDK for that matter. We submitted a grant on diabetes and pancreatic cancer, and the cancer group sent the grant to the diabetes group saying that's where it belongs. And we said, no, they don't know anything about this connection. They're going to reject it. No, they know everything. They'll do it. It got rejected, and it got a terrible review. It said, you don't know, you are studying a link which is meaningless.
Hmm.
So there is a gap between the understanding that endocrinologists have of the connection, partly because they don't see it. But now they're talking about worsening long-standing diabetes as a marker of pancreatic cancer, which is something they should be seeing. And that is being talked about as another approach to early detection, is looking at long-standing diabetes and seeing that getting worse as a marker. But I agree that both the ADA, the NIDDK, the diabetes part of the NIDDK have a very poor understanding of this link.
So just to add to that, as the outreach chair from New Jersey, my job is to try to go to health fairs and things of that nature to bring awareness to this. So what I try to do is partner with a local affiliate of an ADA, and there we can educate the people that are coming to these fairs to be aware of this if you have late onset diabetes.
Yes, so Aggie, I just got an email from Barbara saying that she wants to connect me to the new ADA chair and reconnect and try and see if they will do more to publicize the fact.
It's overwhelming. The presentation was wonderful. And I mean, the work continues.
Of course.
That's the message I can come up with, is that we have a long way to go.
Long ways to go for sure. It's
Chari,
yeah.
this is Jianjun Zhang from Indiana University. May I ask you a question? So
Please. Yeah.
I found some articles, some study shows the CA19-9 level was increased in patients with type 2 diabetes compared with control subjects. Did you have data to investigate the C99 trajectory
Yeah.
in relation to time to diagnose new onset the type 2 diabetes.
Yeah, so interesting you mentioned that because we had measured CA99 in 100 new-onset diabetes patients at Mayo, and we found even lower incidence of false positives than we normally would see. I thought that was just a small sample size, but we didn't see any increase. But in terms of trajectory, that's something we are going to be able to do in this study we are doing, not the EDI, but there is a new-onset diabetes cohort that's being assembled, 10,000 subjects with new-onset diabetes that's going to be serially followed for 3 years with blood draws. So there we will have serial blood draws on patients with new-onset diabetes, and we can certainly test the hypothesis whether CA99 fluctuates more in patients with new-onset diabetes compared to controls.
Yeah, that's exciting resources, I know. So
Yeah.
thank you.
Okay, yeah.
Any other questions? Well, we thank you. Thank you for this wonderful information.
Thank you for the opportunity. Yeah.
See you soon.
Yes.
Thank you, Dr.
Thank you all.
Chari.
Yes. Thank you.
Thank you, everyone.
Take care.
Mm.
We can-
Great presentation.